Dr. Nanos, I cannot believe that it's been like 6 years since we last connected on my podcast. I went back and looked. You were my seventh guest on the show. And you know what's so funny? We were both recording in a closet over Skype. I never even saw you.
I know, that's right. I'm so happy.
Right?
I'm so happy you reached out and I'm so happy to reconnect. And I can't believe it's been that long. And yeah, we go way, way back. It's awesome.
I know you're so amazing. And you know what's interesting? The episode was called The Future of Medicine, and we talked about the fact that you were innovating in the medical space, had started a concierge practice, offering all these other complementary services, like how you're all about preventative medicine. And you know what's so interesting? You mentioned in that episode that heart disease was the number one killer of women. I had never heard that. And then I also didn't let it sink into my brain. I had a cardiologist come on and talk about heart disease a couple times on the show. And even though you hear it, it's still, I don't know, sometimes it's hard to like wrap your head around it. And you did a newsletter, like a blog that I happened to receive. And it was called How Good Cholesterol Almost Killed Me as a Doctor's Wake Up Call for Women's Heart Risk. And I was like, I got to get Dr. Nanos back on the show to talk about this because you're a physician.
Yeah,
And
yeah,
you were in a
no.
very scary situation. So tell us what happened.
I was almost a statistic. Yeah, so I've always had like some kind of borderline high cholesterol like most of my adult life into my like 30s. I started noticing it in my 30s, and for years my labs, technically on paper they looked okay. Like my HDL, my good cholesterol was really high, and that cholesterol ratio that we used to talk about is was looked ideal. And so most doctors would reassure me like I was heart healthy. They were all like, fine, you don't need to be on anything, you're good. Well, that almost cost me my life. Um, my LDL, which was my bad cholesterol, was always just borderline high. And so that's where the dangerous part of it really, really lies for women. You were just vulnerable to this illusion, and then we're, under tested, and our symptoms are dismissed. And so, and like you were saying, most women have no idea that heart disease is the number one killer. So around 2020, I got so there's lots of different kinds of cholesterol tests out there. The old standard is the one that gives you this three-digit number that, you're told if it's under the total cholesterol should be under 200. And then you look at the breakdown of the bad cholesterol. Well, that is an old, archaic, completely outdated test. The better test is something called a lipid NMR, and that looks at a much bigger component, many more components of the cholesterol molecule, and gives you a much clearer picture of your stratified risk for heart disease. One of the numbers, and they look at these, they're broken down into larger numbers. So the main number we're looking at there is something called the LDL particle number, or the LDLP. And that is the stickiest part of the cholesterol molecule, the kind that just sticks onto your coronary arteries and forms plaques. And that's really where we get the most information when we're actually doing a cholesterol reading. And so I never order that old test anymore. And I hadn't ordered it for many years. Um, and so in our practice, we only order this more advanced cardiac testing. And so my LDL particle number, and it's the normal range is under 1,000. Mine was approaching 2,000. And so even though if you look at that old test, my number looked okay, on this more expansive test, it was really in a dangerously high level. So at that time, I decided, okay, I talked to my doctor, I should probably be on a statin. I went on a low dose statin, and it started to come down a little bit. Um, and then I was been doing a lot more reading about another cardiac marker that no one tests for, called lipoprotein little a, or LP little a. And this is a fascinating number, a fascinating cardiac biomarker, because it has nothing to do with your diet, with your exercise level, anything. It's purely genetic, and it's the most inflammatory, most dangerous part of and it's sorry, it's the most inflammatory marker, and it's the most dangerous, and it's invisible on all standard labs. So you can actually have a perfect cholesterol. You don't even have to have any elevation anywhere, and you can still have a sky high LP little a, because it's, and this one's super sticky. It promotes clot. It accelerates plaque formation. You can be fit, clean, never smoke, and still have this super high. And women and people have no idea. And most women are not tested. Most people aren't tested, but women even less so. So so in 2020, I decided to like get this checked out, just kind of random because I'd been reading about it. Well, mine was 207 and the normal is like under 75. And I was like, holy shit, this is not good. So
Oh my
I
God.
t- so I talked to my cardiologist, and I have lots of doctor friends, but one of my good friends is a cardiologist who saw me as a patient, and we ordered something called a coronary CT angiogram, which is called a CCTA. And most people have never heard of this test, and so this test is back in the day, the only way we can look inside the coronary arteries was to go through with a cath, an angiogram, and look through with a camera. Now, with CT advancements, we can just use some contrast dye and get all of that same imaging without having to have an invasive test. It's a super cool test. So I had that test done, and lo and behold, I had a 50% obstruction of my LAD artery, which is the Widowmaker artery. And I had no symptoms, no pain, nothing. I had just hiked Machu Picchu with my son. And so I was in like the best shape of my life. And I was like, how is this possibly happening? Um, so I went on a drug called Repatha, which is the PCSK9 yeah, PCSK9 inhibitor, and it's an injectable drug that really works much more effectively at reducing that LP little a, because statins don't really help reduce that LP little a. There's really not much except those really advanced drugs that do that. And so now, a couple of years later, I got another CCTA and my plaque is totally stabilized. I'm going to make it, it's going to be fine. But it was such an incredible wake up call because I do not look like I don't fit the picture of someone that you think would be having like a major cardiac coronary artery obstruction. So I feel like it's my duty now to educate the world. That's
Absolutely. And you wrote on the blog post, this post could save somebody's life. And I agree with it, which is why I invited you on immediately. I actually sent it to my parents, both of them, to my mom and dad. And I said, read this. Has your doctor ordered these tests? Like, what have they told you? Because, they're in their 80s, but it's important for every
yeah.
woman at any age to be aware of all of this. And the lipoprotein A, interestingly, I had heard about it back in 2022 on somebody else's podcast, a doctor's podcast. And I remember asking my doctor for it. And at the time, like you said, it's still considered like it's
Yeah.
not the norm to order, right? So I don't think my
It's
insurance
by
wanted to
no
pay for it.
it's by no means the standard. Even that lipid NMR is still I have no idea why everyone is not ordering that test. I've been ordering that for almost like 8 years now. We're stuck in these old patterns. Insurance dictates these archaic ways of practicing that aren't benefiting patients, and women don't know to advocate. And the thing for women is that we are our cardiac symptoms. If you have most women don't have the classic like clutching chest. You picture a heart attack, you think of a middle-aged white man like clutching his chest or having neck or jaw pain. That's not what it's like for women. Some of them have no symptoms at all. Some of them just have fatigue, indigestion, anxiety, jaw pain, like sleep disturbances, very vague stuff that a lot of women often experience. So what often happens is when women die from heart disease, it's usually a one-time fatal event before they've ever had a single symptom. That is how it happens for most women. And heart disease kills more women than all cancers combined. Combined. And same for men, but that's just such an interesting statistic. And not that we shouldn't be worried and proactive about cancer, but there's so much we can do in the area of heart disease. So that's what the message I'm trying to get out there.
Okay, so there's a lot that I want to sort of walk through with this because it is so important. And I really do believe somebody's going to hear this and it could save their life. If you are a physician and you're being told everything looks great and normal, that's what we all want to hear when we're the patient.
Right.
Your knowledge and your, got you and your gut, I think I read it that it was sort of your intuition was saying, you know what, maybe I should take this a step further, got you to pursue it beyond just accepting that everything's okay.
Right.
So let's break down a few of the things you talked about. Okay, so lipoprotein little a is a
Yep.
genetic marker.
Yes.
If somebody goes to a regular doctor versus a cardiologist, will that doctor we order it or can you request it or
Yeah, you can absolutely request it. Whether or not they order it depends on the doctor, depends on perhaps your your whether, if you're in like a strict HMO kind of practice, like a Kaiser situation, they might not order it. If you're like Kaiser Sharp HMO, those kinds of environments for primary care may not support that. So you may have to advocate more aggressively or pay out of pocket or something like that. But it is becoming more, doctors are more aware of it now. It is kind of, there is a light being shined on it. So I think there's more acceptance about around ordering it. And it's just, if, if hopefully if a doctor is willing to listen to you, which if they're not, you should probably find another one. Um, then, they should order it. Yes.
yes. And I think what's frustrating is what you said that a woman could go in and oftentimes, even with the most well-intentioned physician, be told that you're fine, normal aging. Like if you're bringing up some of the symptoms that you just mentioned about like sleep disturbances or right jaw
Yeah.
pain, like
Right.
they're thinking about maybe how it's presenting for men and not maybe thinking about women. And with women, which is, I don't want to jump too far ahead, but I do want to talk about perimenopause and menopause and also
Yes.
how that plays
Yes.
into it.
Yeah.
So, are men more likely to have these tests ordered for them? Do we know?
Absolutely. Yes, absolutely. Unfortunately, um, men's heart disease and cardiac preventive health is taken much more seriously than women, unfortunately. And it's part of all of the studies around heart disease were focused on men when they were originally done. So they just their symptoms, and when they die of heart attacks, it's much more dramatic. And it just gets more attention for some reason, which is completely it does a disservice to women because we are dying at the same rate and with far less prevention and less explanation as to how we can prevent this.
Okay. And you climbed Machu Picchu, which is amazing, by the way. I want to do that too. I really want to go on that trek. But you could have had a Widowmaker heart attack on that,
Totally. Yes.
which
Yes.
is so frightening. So just let's go through, just talk, let's have the women really take in. So go through, if you don't mind, again, some of the symptoms that how women present with it. Like if they're having symptoms that there might indicate that there's heart issues.
Instead of the just classic chest pain, I mean, everybody can still present with chest pain with exertion. So typically, when the classic sign is this, not necessarily pain, but like pressure on the chest, feeling like heaviness in your chest. That is the most classic sign, and not to say that women don't get that sign. That is a very concerning sign that you should absolutely get immediate medical attention for. And it's usually brought on by exertion. But other things are more subtle, like feeling fatigued, feeling like you just can't like get any kind of energy back, even when you're doing everything you possibly can to optimize your sleep. Indigestion, chronic indigestion, and kind of heartburn can also be a subtle sign. A lot of I've seen instances where patients have jaw or back pain or shoulder pain, and it ends up being of cardiac origin, which completely takes them by surprise. So, and oftentimes these symptoms get brushed off as, oh, it's just stress, it's midlife, it's perimenopause, you'll be fine. You'll be fine, you'll be fine, you'll be fine, until you're not. And so that's why they never get that preventive care, they never get it further testing. And when they have their first cardiac event, it is usually that fatal heart attack. Women are far more likely to have their first cardiac event be a fatal heart attack than men.
Yeah, because they're not being taken seriously or being given the test that they need or know what the
Exactly.
symptoms are. Nobody's talking to them. They're just
Exactly.
because we're
Exactly.
presenting differently. Okay, so let's first talk about the testing. So you got the lipoprotein little a. Insurance may or may not cover it. Uh, you mentioned lipid NMR, so that would be another one, right?
Yep. Yep.
What
So
other markers would be worth looking at?
so I tell, I tell all, obviously I do this for all my patients, but all my friends, family, people who ask, I tell them first you want to ask for a lipid NMR instead of that old standard crappy like 3-digit lipid panel. That's going to give you a lot more information to start with. And then you also at the same time should ask for a lipoprotein little a, and then also an apolipoprotein B. So
Yes.
very long, complicated words, but ApoB is what we call that. And then I also like to sometimes look at a homocysteine, and I'd also like to look at like a cardiac CRP, a C-reactive protein. And those are the homocysteine and the CRP are just more general markers of inflammation. They don't give you as much specific information, but the apolipoprotein B and the lipoprotein A are more specific cardiac markers. So that just gives me a lot of information. If all of those are pinging as high, that there's a more intense inflammatory state going on in that person's body that we need to kind of be attuned to and investigate further.
Okay. And I did get tested for that apolip, whatever the B one is too, the long one you
Oh,
just said.
ApoB, yeah.
Yes, I did get tested for that too. But here's where it can get tricky for somebody who's not in the medical system. You get the results, and then sometimes you don't even know what to do with it unless it's been like flagged and then what to do next. So, what does that marker tell you? Because I've gotten results, but I don't even know, like, I think it was within the range of normal. And also, is that range based on men or is it general
No,
population?
that range is okay. That range
Okay,
is
good.
general population. So there's two different depending on the lab you go to, there's different reference ranges. Some measure them in different units. So I'm not going to give you like a general, I don't want to confuse people by giving the actual numbers, but looking at the reference range in that lab that you got from the lab you got done, if you're within normal range, if your lipid NMR is perfect, if you have no ApoB or lipoprotein little a, that's all normal, then you're good. That is a good thing. You can rest easy. You're going to be okay. You're going to
Yeah.
make it. You're probably not going to die of cardiac disease, but
Yes.
you should continue to optimize your diet and exercise as much as possible. So I think for most people, you can stop there. If anything on those labs, like on the NMR, or if the lipoprotein little a or the ApoB are elevated, then the next step is really to get this coronary CT angiogram or a CCTA. And that's something that almost nobody talks about, and insurance really doesn't cover unless you are like they covered it for me because I had like all these other risk factors, but a lot of times they're not going to cover it. And it can be a pricey test. It's about like if the insurance doesn't cover it, I think it's about like $600. So but it is a life-saving test for a lot of patients. Um, and so if any of those tests, if any of those previous labs are abnormal, then getting a CCTA is really an imperative next step. And insisting upon that, I think, is critical.
Okay. Can you tell us what that exam looks like? You said you used,
Yes,
they
yeah.
did some,
So
yeah,
that's
please.
it's a CT scan. It's a CT scan, so but with contrast dye. And you have to take a medicine called propranolol to lower your heart rate. They want your heart rate to be under 65. So I'm really good at lowering my heart rate on my own, but most people can't get their heart rate down that low. So sometimes they may ask you to take this heart rate lowering medication prior to the test, which is pretty typical. And then you're given contrast dye, IV contrast dye. But prior to that, they want to make sure your kidneys are functioning well. And so you get the contrast dye and you go through the little CT tube. It's not an MRI. It's not like that coffin-like feeling that people get freaked out about.
Yeah.
It's just really a circle. So you're just going through like the CT loop. It's like a ring.
Okay.
Um, and then the whole thing takes like under 20 minutes. It's very, very
Oh,
fast. And then that's it. You're done. And so with those images, they can actually look at your all of your coronary arteries and tell you exactly what level of patency, like how open they are, if there's any plaque formation, where it is, what percentage of the artery is obstructed. And it's just, I think it's one of the most fascinating advances in medicine. I mean, we used to have to literally go through someone's groin with a camera to get all of this information. And
wow.
that was a really risky test. It's still done all the time. We do that test prior to putting in stents, but now it's only reserved for those interventions instead of just for, further diagnostic assessment. So it's a big deal that we can have this information without having to do such an invasive test. And really, like, I know $600 sounds like a lot, but it is a life-saving test for so many people, and it was for me. So
Yeah.
it's really critical.
And on the medication now, does it dissolve the plaques? Like, did it actually, or how does that work?
So what it does, the Repatha, which is the PCSK9 inhibitor, works by stabilizing the plaque. Oh, this is the other really important part that I want to mention about the coronary CT angiogram. So it
Yes.
also does a coronary calcium test with it. So a lot of people confuse a coronary calcium score with this CCTA, and they are really not the same. So lots of doctors will order a coronary calcium score.
Yeah.
And that's great. I mean, that's awesome, but it does not give you any information about soft plaque. And so it looks at only hardened plaque that's calcified, and that's what that's measuring. So if your doctor just orders a calcium score, that's just part of the equation. That's not enough. And so if you have any abnormality and you get a calcium score and say your calcium score is 0, that gives you this false sense of reassurance because that's only measuring the hard plaque. And it's the hard plaque doesn't even impact you as much as the soft plaque. It's that soft, unstable plaque that can kind of peel off the inside of the coronary arteries and float out and cause a heart attack. So we don't even care that much about the hard plaque. I mean, we do care, but like it's not as dangerous as the soft plaque, and the calcium score by itself is not measuring that at all. And so that's the other miscommunication out there. People think, oh, I had an abnormal cholesterol, I had abnormal LP little a, but my calcium score is fine. No, that's not enough. You need to look at the only way to look at the soft plaque is with this CCTA, the coronary CT angiogram. You're not going to get that any of that information through just the calcium score alone. So that's the other really, really important piece there.
I was actually going to ask you that because I literally noted it because I was going to ask my doctor for the coordinated calcium score test.
Right. No. If you're gonna
No,
if you need that, if you're going to get tested again, you need the CCTA, the
I
coronary CT angiogram.
literally never even heard of it. And what about the one that does your
Most
neck?
doctors haven't even heard of it.
Well,
Um,
why? Can I just wait? Okay, so yes, so tell us why, and then I want to know about the one for the like the ultrasound of the neck, which I've also had done.
yes, that's the carotid ultrasound. That's also very, very helpful. Most doctors are operating in an insurance-based world where, as horrible as it is to say, they run the game, and it's not that doctors don't want to do better. It's that their hands are tied most of the time, and they're limited by what they can order, what they can even consider ordering. Um, I am fortunate to have not been in an insurance-based medical practice for a long time. And so that allows me to explore a lot of other more sophisticated alternatives and advancements in medicine that are not yet covered by insurance, but that we know have, you know, tons of clinical evidence supporting their efficacy, and it's really frustrating. I'm lucky that I'm not in that world and I can operate outside of that world, but most doctors can't. And it also limits what they pursue in terms of what they're studying and what they're looking at and what they're reading. So that's another piece of it. It's really sad.
That is, and probably frustrating for the doctors because they want to be offering more. Is that why they sometimes push back on labs when you ask for labs? Is that the
Well,
what reason?
yeah, yeah. Absolutely. Well, and they also and it's not just they can order whatever they want, but then
They have to
they're
code it.
and they can code it too, but like they're not going to, so they will know it won't get covered. Then there'll be a prior authorization that comes back. They'll know that that's still not going to get covered, but they got it creates all this additional work for them and then frustration for the patient. And so in order to avoid that, they will just not order it.
Okay, that's really helpful. Okay, so tell us about the carotid artery test, and do you recommend that too?
Yeah, so the carotid arteries are right here in your neck and they feed your brain. And they are also a great test. I don't order that as frequently because typically, if we're doing all of this cardiac testing and there is an abnormality, we'll kind of go to that next. It's not usually the first line. I usually will start with most of that other cardiac testing, but it is an important test to have. It's certainly because a lot of people don't realize like a stroke is basically a heart attack in your brain, and it's a lack of oxygenation to the brain. And so those carotid arteries are feeding your brain. And if there's stenosis or narrowing of those carotid arteries, that is how you can also develop a stroke. So your brain is just as important as your heart. So it's important to get those checked out too. Um, but I usually start with the cardiac stuff first.
Okay, and is it looking in the neck at soft or hard plaque?
The ultrasound is usually looking at the hardened plaque.
Like the way the
Yeah,
coordinated calcium score does, similar?
similar. Yes.
Similar. The only reason I asked is because one of the takeaways I had is when you were writing about your risk, the risk based on your labs and what you was discovered also means that possibly you were at risk of stroke too, right?
Right. Yeah.
So
Yeah.
one or the
Yeah.
other could have hit.
Right. Right. Exactly. Um, and really if so there's a couple of different ways to do the carotid ultrasound. If they're using like the Doppler flow, they can look at both the soft and the hard plaques. So you can look at blood at both because they're looking at the blood flow velocity through the artery.
Yeah.
Um, so you just got to make sure that you're getting that full expansive test.
Okay. Talk to us about menopause, perimenopause, heart related stuff for women to understand their risks, especially once they enter that season. And part of what you want too is to have a baseline. Like that was partially why I was
Yeah.
thinking I'll get a coordinated calcium score, never having heard about the CCTA until your blog post. So
Yes. So menopause and perimenopause. So perimenopause can start as early as, your early 40s. And when women start to enter perimenopause, their estrogen levels decline. And estrogen, more than being just a reproductive hormone, has very protective effects on our cardiovascular system, on our heart. It helps keep our blood vessels flexible. It supports healthy cholesterol levels. It improves glucose metabolism. And so when estrogen starts to fall during menopause, this cardiac protection starts to decline. So not only, estrogen also affects our mood, it also supports our brain hormones as well. Um, and so a lot of things start to kind of shake up when estrogen starts to fall. And then also during menopause, women's body composition shifts to more central visceral fat after menopause. We become sometimes less metabolically active, and that also raises our risk. And then blood pressure also rises during that time.
yes.
So all of these things accelerate our risk around menopause. Sorry. What uh, I think what's really important is that when women are in their perimenopausal period, um, that they are actually being very aggressive about getting these cardiac tests done, understanding what those numbers are, and if they need to be on estrogen hormones, that they can be cardioprotective in that time during peri and pre-menopause. There is it's kind of there's a window, there's a cardioprotective window about 10 years in perimenopause that actually helps women. So if they were to go on estrogen in that protective window, say like 45, and they have some cardiac risk, it can help. However, if they are already experiencing, cardiac risk factors, or sorry, if they already have stenosis, if they already have all this cholesterol built up, and they're in their postmenopausal years, then that estrogen may or may not be helpful. So it's really important to have a nuanced view. So, like my situation, for example, I'm 53. I'm going to be 54 in a few weeks. I am postmenopausal. I'm not on estrogen. It may not be the safest thing for me, given everything that's gone on with my heart. But that's why but I'm on progesterone because it helps me sleep. Um,
Oh,
so it's such a nuanced conversation. Um, but had I been on estrogen maybe 10 years ago, it could have helped me. But at that time, 10 years ago, we were still in this world where hormones were bad. And so, just for our listeners who aren't familiar with this whole hormone um, shift in thinking in the medical community, what happened was about 20 years ago, there was a study called the Women's Health Initiative, and it kind of turned the tables on hormone replacement therapy. And the whole idea 20 years ago, hormones were bad, women shouldn't take them. At that time, everyone who was on hormones was taken off of them. And for 20 years, this is when I was in medical school and in residency, we were taught, do not give women hormones. It's going to give them breast cancer, heart disease, strokes, all this stuff. And so that was how we all practiced until about five 5 to 10 years ago. That started to be relooked at. We saw that all of the data, much of the data from the Women's Health Initiative was very flawed. And in fact, they were looking at much older women post-menopause in that study. And in fact, putting women back on those hormones was cardioprotective instead of putting women at greater risk. So the whole tide has shifted, and there's still not a lot of physicians who are aware of that and who practice that way. And so we have to relook at how we think about HRT, hormone replacement therapy, who's the good candidate. And it's a very detailed, individualized conversation for women, that you see is like it's different for every single person.
absolutely. I'm still actually in perimenopause at 54, but I just went on hormone therapy like 2 months ago,
Good.
partially for my bones because I
Yeah.
have
Well, it's
osteopenia.
right. Everyone's got, that's the other thing. So some women will go on it for sleep, for hot flashes, for memory, for brain fog, for their bones, for their heart. I mean, everyone's got different reasons. And so it's so important for women to have these deep, honest conversations with their providers. And if you don't have someone who's going to listen to you, find someone else. I mean, you have to advocate for yourself. Women have to do this in medicine because we are often dismissed and unheard and just kind of told you're fine, deal.
That is
It's not.
100% true, but that's so hard. So even doctors have come on and said that that's been their case when they're the patient. So how can we better communicate? Is it data? Is it not apologizing? Is it not over explaining? Like, are we part of the issue? Like, or is it the system? Like, or is it a combination? Like, how can we better get the care that we deserve?
A good question. I think it's definitely a combination. I think
Because even female doctors,
no, I know. And I was guilty, at least of the hormone piece until like a few years ago. Um, I think it's about coming armed with information and having Um, it depends on what part of the medical care system you're in. So if you're in like a traditional practice where you get 5, 10 minutes, um, then that's very, very challenging. You want to cover like your, your what your top most important concerns, and that may not be on there. But and especially if you're going in to see your doctor once a year for a physical, they're not going to want to talk to you about all of this stuff that's like they deem as kind of bottom of the list where they're trying to tackle all of your preventive care. So a physical is not really the place to have this conversation,
Yeah.
because there's just no time because you're trying to do all this stuff. And so the key, I think, in the traditional medical model is to just keep making new appointments for that one specific issue and not trying not to tackle too many other topics in the same issue because you're not going to get them all covered. And so just know that your doctor really wants to help you, but really only has that 5 to 10 minutes. And so I would start with having like a separate visit just to talk about your hormones. Come armed with information, questions, make a list, write it down, um, and uh, and then I think that's a good starting point. And then advocating for yourself. And if someone's not, if you're really feeling dismissed or unheard, then you have to find someone else.
That's such great advice. I think that's really such great advice because oftentimes we just wait for the annual exam
No.
and we have a list of 10 things that
Nope.
we've been thinking about. You're totally right. That probably would help
Yeah,
a lot.
that is, I mean, that is the doctor's nightmare when they come in and there's like a list like 10. It's not for me because I have a different kind of practice. I'll sit and talk to you for an hour. We have that luxury in my practice. I have a
That's so
concierge
interesting.
practice, but when I was in that model, it was the worst because that the physical typically the physical is just for preventive care. That's the whole idea. You're
Oh,
talking about your mammograms, your colonoscopies, all that stuff, your PAPs. It's about prevention. And so
okay.
anything outside of that, there's really no time for that. But people don't understand that that's the point. And so there's a lot of frustration on both ends. And so if you have other issues, you should actually make a separate appointment for every single issue in order to get it addressed properly.
That is
And that
such gold. This is so helpful
and that
because
that will make your doctor very happy and that will make you very happy. So if you come in with one problem that you just want to talk about in depth, oh my God, you'll get it covered. And your doctor will be like, "That's it? Yeah, okay, let's talk about it." So,
do you know how helpful it is to have a physician's perspective? Because obviously you were in the traditional model before you went off into your concierge. So thank you. That's like that alone is huge. Um, because even we just took our dog to like his well visit, and the doctor's like, "Oh, I see there's a lot to cover today." I'm like, "There's like three things that I mentioned, but it was on top of probably the normal like what
right,
vaccines is he due for it and whatever." So in
right,
his
right.
head, it may have been the same thing where he's
Yeah,
like,
no,
"You want me to
exactly.
look on the thing on his nose and the thing on it, and
Yeah.
I'm realizing because in his mind, because I got that sense that he thought it was a lot. And I'm like, really? Like I just am bringing a couple extra things on here. But no, it's a window of time that you get with the doctors. Okay. So we talked about so much already. You mentioned a couple times metabolic health. What labs or what checks metabolic health? Is that the triglycerides? Like what looks at the metabolic health?
So when I'm talking about metabolic health, I'm talking about your blood sugar as well. Just being aware of how blood sugar impacts our cardiac health, um, and being at risk for diabetes or sorry, having prediabetes or diabetes puts you at much higher risk for heart disease. So monitoring your blood sugar levels is really helpful. Right now, there are so many people on GLPs. It's been a life-saving drug for a lot of people, and getting that weight down has really helped a lot of women and men reduce their risk for heart disease. So it's really about blood sugar, weight control. I myself was on Manjaro for about a year and a half when all of this was happening. I really felt like I had to do everything in my power humanly possible to optimize my weight and get in the best shape of my life to stay alive, really. I mean, truly, like had I not advocated for myself, I would either would have already had a heart attack or would have had one in the next couple of years. And it's just, it was such an incredible wake up call for me. And I think I've been thinking so much about my mortality in the last couple of years. It's kind of a weird thing to do at 53.
No, it makes sense because you basically saved your own life by having curiosity, trusting your intuition, and following up on that and making sure that you did get the test that you knew would most reveal what was happening. And your instincts were correct. You are someone who believes in women marrying their intuition with science. Maybe that would be a good place to sort of wrap up. What can you say about trusting our gut and then sort of pursuing it with a doctor so that you're both on the same page? Because sometimes a woman's intuition isn't necessarily counted as valid enough data for a doctor to act.
Yeah, no, that's a great point. I think nobody knows you better than you, and I think I actually, okay, this might not go over well, but I really prefer only going to women physicians because there's lots of data behind this. Women are better listeners and outcomes with women physicians tend to be better. I'm sorry, guys, there are lots of great male doctors out there, but I have found that I get better care with female doctors. And so um, something to consider, just putting that out there. But even so, it's about again advocating for yourself, trusting your intuition, knowing if you feel something is just not quite right, it's probably not, and it just requires more digging. And getting other opinions. Don't be afraid to get another opinion, especially if you have, a serious medical condition. I say this all the time for, patients with new cancer diagnoses. Like, get as many opinions as you need. No one is going to be offended. No doctor is going to be offended by you getting another opinion on something. I welcome more information and more input from other doctors. More brains are better than one. So that is okay. Like, solicit other opinions if you're not happy with what you're hearing. And I think it's again like advocating for yourself, putting yourself first, actually going to the doctor. Let's talk about that, like actually making those appointments, making yourself a priority, doing the basic prevention, mammograms, colonoscopies, pap smears, all that stuff, and realizing that, the whole thing about putting your oxygen mask first is has never been more important. We're putting everyone before us, and I think that's really where it's at, prioritizing our own self and our own self-care.
Absolutely. So before we wrap up, is there anything I didn't ask you that you just want to make sure the women take away from this conversation? For me, it's the fact that something you wrote about most women who end up having that fatal heart attack didn't even have symptoms. So take it wherever you feel, but I will put that out there because, like, think about that, ladies. Like, that's so scary. Like, don't ignore your body.
Yeah, the thing with heart disease is that you're not gonna feel it. You're gonna feel fine until you're not, until you're dead from that first heart attack. So all of these are silent symptoms. Same with, like, diabetes, hypertension. If you're not getting checked, if you're not getting all of this testing done, you're not gonna know. There's no big warning signs sometimes. And so being proactive, focusing on prevention is so key. And again, advocating for yourself, advocating for other women. I really believe in the power of women standing together and helping support each other. And I think that's the key.
Absolutely. And you're sitting with your kind sign behind you. I mean, this lady, she named her practice Kind Health Group. This woman is
I did.
remarkable. I am so happy to be sitting with you again.
I know,
One of
me
my
too.
first guests. I'm gonna actually I want you to go listen to her story and why she started her practice. Speaking of which, where do I direct my audience to learn more about you and the work you're doing? Like, where can they
Yeah,
find you?
absolutely. So we have Instagram at Dr. Georgine Nanos. We have our Instagram account at Kind Health Group, on Facebook as well. And then our website is kindhealthgroup.com. one day we can talk about TMS. So we'll do that next time. We also have a TMS practice in our within our clinic as well. So maybe we'll cover that one next.
Okay, and I saw that I was doing my research. So yeah, just tell my audience what TMS is, just since now we've given them an acronym because I'm not as familiar either. What is that?
So TMS stands for transcranial magnetic stimulation, and it is probably the most safe and effective treatment we have in all of medicine for mental health disorders. So grossly being underutilized, but we are bringing it to the forefront, and it's FDA approved. It's been around for 40 years and no one knows about it. So that'll be our next topic.
So this is why I appreciate you so much. You're always on the cutting edge. You stepped out of a traditional system, which took so much courage. We literally called that episode because I was like, you're rewriting the future of medicine. I wish that every practice was like yours. I wish every woman could get the care that you give, Dr. Nanos. You're so incredible. And you are a true advocate for women. You are a true advocate for women. So thank you for being here today. I'm super grateful. This conversation is going to save a woman's life. It just
I
is.
hope it does.
It
Yes, please
will.
share it. Share it with
That's what I was
everybody
going to
that you
say.
know. Thank you.
Yes, share it with every woman that you know and even the men. Let them go get checked too. That's fine. Although they're
Well,
probably
yes.
getting taken care of anyway.
Well,
Um,
no, they're not either. You know, that's the crazy thing. You hear all these stories about like these guys that ran a marathon and then dropped dead. It's because they don't even go to the doctor at all. And what it is, they have all these same markers that they're not getting checked at all. At least we often have to go for gyne issues, and so women have more encounters with the medical system because of that. But men, like there are men who haven't been to a doctor in 10, 15 years.
yes, share this interview with everyone you know, all the women
Yes.
you love and know, and every guy, because these same tests should be done so that we can live as long and healthy as possible and not have anything like this come out of the blue that we didn't even know was happening in our bodies.
Yes, most heart disease is preventable.
That's so important. Everything you shared has been amazing. So grateful to be back with you again.
Oh,
And
thank you
yes, come back
so
anytime.
much.
We
I'm
should talk
so much.
GLP-1s. We should
Oh, we
talk.
can talk about all of it. Yeah.
Yeah.
Thank you so much. This has been so much fun. I'm so happy that you reached out.
Oh, I'm so happy to see you. And ladies, send in your questions. Maybe we'll just do a part two of just like ask the doc or
Oh,
something.
yeah, you
I'm
can ask
open
me
to it, right?
anything. Oh, totally.
You're
Yes.
so great at that. Go follow Dr. Nanos on her social and for taking the time to be here.
Thank you, Michelle. Have a great day.
You
Bye-bye.
too. Bye bye.